today we're pleased to have Professor Mihaela van der Schaar, who's a professor of machine learning, artificial intelligence, and medicine at the University of Cambridge. Mihaela is also a fellow at the Alan Turing Institute in London and a Chancellor's Professor at UCLA. Mihaela's research on machine learning and AI focuses on healthcare and medicine. So we're very excited for Professor van der Schaar's talk, which is entitled Revolutionizing Healthcare, Turning the Practice of Medicine into Quantitative Science. I'll now hand you over to Mihaela.
Thank you very much, Karen and David, for the kind introduction and for inviting me to give this talk. I'm really excited to be here and talk to a clinical audience. I would like to start with a quote from William Osler. If it were not for the great variability between individuals, medicine might as well be a science, not an art. And indeed, medicine is hard. And the goal of our research lab is to develop artificial intelligence and machine learning methods aimed at turning medicine from art to science. And in this regard, we have 5 main goals. First is to turn machine learning, with the help of machine learning, medicine to go beyond just personalized and precision medicine into something I call bespoke medicine. And I'm going to define this term a little later. Then the focus will be to empower healthcare professionals with better methods and tools to better take care of the patients that they are seeing. So the focus is on empowerment, not replacement, using machine learning and AI. Also, we aim to use machine learning to build proactive, data-driven and machine learning-enabled system pathways and processes in healthcare. Enable a more quantitative approach to population health and public health policy in a data-driven way using machine learning, and enable new discoveries both in the clinical domain as well as new therapeutics. I'm going to try to see if I can hide this. Yes. So a few months back, we have developed a unifying framework for addressing these challenges in healthcare. And we have identified 4 key pillars where machine learning can play a role. The first is patient-oriented and focuses on the individual patient. And that is bespoke medicine. And I'm going to talk a little bit about a variety of methods that we have developed to deal with screening and monitoring longitudinal trajectories of disease, treatment effects at the individualized level, etc. Also, from a professional point of view, we use machine learning to empower healthcare professionals. So we need to use AI in a way in which is interpretable, explainable, and trustworthy. And I'm going to talk briefly about that today. Then if we move beyond the individual at the population level, it is really my belief that machine learning can empower a variety of data-driven guidelines, standards, but also enable us to learn faster at scale from the wealth of the available data. And that has been highlighted very clearly by this current pandemic. And last but not least, system pathways and processes in healthcare can be empowered using machine learning. If you want to read about these different pillars of our research and what machine learning can do beyond the talk today, which is relatively short, I invite you to take a look at the website dedicated to this framework and read more about it. Also, I would like to say up front that we have developed an engagement session in our lab that we call Revolutionizing Healthcare, which is aimed at healthcare professionals, medical professionals, as well as students who are interested to learn more about machine learning. So if you are interested in this area and you would like to learn more about what machine learning can do for you and also shape this area, please subscribe to this engagement session and talk to us more about it. I also want to say that this engagement session now has certification, so you can get credits from it as well if you are a practicing clinician. And if you want to learn more about the framework itself, in our second session on Revolutionizing Healthcare, I'm describing the framework in detail. But today I'm going to mainly highlight some of the key methods that we have developed in the last couple of years to enable such a revolution in healthcare. And what I hope that you can see on the basis of this talk is that we can go nowadays beyond what you have seen so far, which is machine learning for better annotating images, whether it is in dermatology or radiology, or using natural language processing to learn from clinical notes. What you're going to see here today is different types of machine learning methods that may be less currently hyped in the media, but which I do believe that can play an important transformative role. I'm going to highlight especially the use of automated machine learning, time series forecasting, causal effect inference for estimating individualized treatment effects, and machine learning interpretability and explainability. If you want though to take a look at what is possible and the wealth of technologies that are currently developed for healthcare, please take a look at our website, which highlights some of the publications that we have at the top conferences in machine learning. So I said that we are trying to move beyond precision medicine into bespoke medicine. What do I mean by that? We know that patients are complex. They have different genetic background, environmental exposures, lifestyles, histories, and interventions. And this translates into different risks over time, variations in symptoms, different health and disease trajectories, and responses to treatments. And if you consider personalized medicine, aims usually to fit the patient to a pattern. This pattern may be complicated, and indeed it may contain genetic information, imaging information, and clinical information. But bespoke medicine goes one step further by recognizing the fact that we need to recognize and adapt to changes in patterns as the patient is aging, changing their lifestyle factors, whether different diseases, morbidities, or comorbidities may set in, and also as the patient is treated for a particular disease. So we will need to really recognize and adapt patterns over time. And how do we really do that? With the help of machine learning. So machine learning can provide us the tools and approaches to empower you, the clinicians and medical researchers, to develop a comprehensive patient view, both a long-term view, which is based on the context of the individual patient, but also a broad view. So currently, many specialties are going to look at just one particular disease and its trajectory, for instance, cardiovascular disease or cancer or diabetes. But it is well known that these different diseases at times interact in complex way. So we are moving not only from a static view based on the current information to a longitudinal view that takes into consideration the entire lifetime of care of the patient, but also considers many diseases and the way in which they interact and their impact on both treatments that are most effective as well as outcomes. For that, the type of tools we are building to empower you, the clinicians, range from risk scores to competing risks, screening and monitoring methods, diagnostic support, longitudinal disease trajectories, as well as estimating treatment effects. Today, I'm going to talk only about a few, but if you are interested more about this agenda, please join our Revolutionizing Healthcare session. I also would like to say that often, with the help of machine learning, we can take lessons that we have learned from one disease to lessons for many diseases and learn formalisms and concepts that could be transformational across a whole set of diseases. Let me start by describing the simplest of problems in that you probably have often encountered: the use of machine learning for building clinical risk scores. We have currently a variety of risk scores being developed, such as Q-risk, etc., etc. But such risk scores are often developed on the basis of a particular set of data items that have been collected based on the current knowledge of medicine. And an important question may arise whether other information from the data, wealth of data that's available, whether it's UK Biobank or electronic health records, should be incorporated as well. And another question is whether a simple linear model is sufficient for issuing a correct prediction for an individual, or machine learning can empower us to do better. And indeed, in recent years, we see a wealth of publications in the top journals in medicine presenting different views about the power of machine learning for clinical scores. One important criticism I have about a variety of papers that exist both in the clinical domain as well as machine learning domain is that they often select only a few machine learning models, maybe a random forest, maybe a multi-layer perceptron, or a particular XGBoost method. But the reality is that we have many methods, and different methods may have different ability to predict correctly depending on the characteristics of the data. So an important challenge we need to address is which machine learning model to choose to issue a prediction for a particular data set. Secondly, we want methods that are reproducible, interpretable, and trustworthy. So the way in which we can do that at scale for many diseases is using machine learning itself. So because we have many diseases, because we may be able over time to acquire new information about patients, so you may want to, at the push of a button, issue new risk scores. And also because the diseases are changing potentially over time, the populations that are suffering for a particular disease may be changing, and also the type of treatments and interventions that we have may change over time. We need to have a rigorous, systematic approach and easy approach for clinicians to use technologies from statistics and machine learning. And rather than use machine learner like me or a statistician to do all that, wouldn't it be wonderful if we can replace not the clinicians, but rather the machine learners and the statisticians, and empower you to be able to generate this at scale at the push of a button? We can do that using automated machine learning, which makes machine learning itself do the crafting of such risk scores. And this is important because you may want to issue many risk scores for many conditions, as I described, and we have many different types of machine learning models can be used. And this is especially complicated since we may need to do data imputation, feature selection, dimensionality reduction, as well as issue predictions. For that, a few years back, we have developed an automated machine learning framework for crafting clinical scores, which we call autoprognosis. And the idea there is that we can take any clinical data and issue predictions by building pipelines. Pipelines that are based on imputation methods, feature processing, classification, and calibration. We are issuing in this way, we are identifying at every stage of the pipeline what algorithm should be chosen and the hyperparameters associated with this particular algorithm. So we need to search using machine learning across a vast set of machine learning methods and statistical methods to build the best predictive pipelines for a particular data set. We are not only issuing predictions, but also explanations associated with these predictions. And I'm going to talk more about that a little bit later. Also, it is important to note that we can not only learn from the data available at a local hospital or even at the level of a country. We can also learn from complementary cohorts from other hospitals or even other countries. And this is challenging conventionally because these different cohorts may have different characteristics, different features, and also the clinical practice may be different in different countries. Yet we can do that in a very elegant way within this type of ecosystem using new machine learning methods based on meta-learning. Autoprognosis has been used for a variety of medical problems since its inception. And here I just highlight a few, from cardiovascular disease in a variety of settings to cystic fibrosis to UK Biobank, in the use of, again, cardiovascular disease prevention, breast cancer, and most recently, COVID-19. If you want to read more about automated machine learning and how can empower you, the clinicians, to build at the push of a button clinical risk scores, please take a look again at this web post that highlights our research in this area and can point you to methods that you can use directly. Let me also say that AutoML is not only able to do predictions, so will this person survive in 3 years, yes or no, but we can do also time to event analysis, so do survival models, deal with competing risks, causal effect models, as well as longitudinal time series models. So AutoML has made in the area of healthcare a big entrance, going beyond predictions to a variety of analytics of interest in healthcare. So now many of these technologies are ready for you to use for the data set that you may have to answer questions that you may pose that are of interest to you and your patients. In this way, you can build individualized, personalized health and disease atlases for the patient at hand. You are going to be able to predict on the basis of the wealth of data that's available in electronic health record, what will be the evolution of the different biomarkers of interest over time, thereby enabling you to do better monitoring and screening of a patient, are able to issue projections of risk and risk over time, building trajectories of disease for a variety of diseases, and also to do time to event analysis. I'm going to highlight some of the methods that enable us to build such disease atlases next. And again, if you are interested to hear more about that, please take a look at our Revolutionizing Healthcare. What I'd like to mainly talk today about is models for health and disease trajectories, where we use a wealth of clinical data that is acquired over time to issue predictions over time for the patient at hand. That is a complicated problem because we need to learn from complex and irregularly sampled data, data that may be not missing at random. We need to learn from limited supervisions because maybe the clinical annotations may be limited, and also the codes that we may have at our disposal to learn from is limited as well. We need to identify how much the history of the patient matter and what particular events or set of events from the past may have mattered for a particular prediction, and learn holistically, given the fact that maybe different diseases, morbidities, and comorbidities of the patient may influence not only the trajectory of that particular disease, but also other diseases. And understand what factors matter and why the evolution of a patient that may be seemingly similar to another may be very different over time. And last but not least, we want not only to issue predictions, but understand what has been done and why these methods are learning something unique that maybe can inform and augment clinical knowledge. If you want to learn more about health and disease trajectories and how we can build it using machine learning, we have collected all our publications associated with this area in this particular website. Today, I want to highlight just one of the many methods that we have developed, which is called attentive state space models. And a power of this model is that it combines ideas from machine learning, such as recurrent neural networks, which are well known to do well for natural language processing and other such tasks, but which are unfortunately uninterpretable and often may lead to a good prediction, but without the ability of a human to understand why the prediction has been like that. And we combine that with probabilistic models that are interpretable and currently represent state-of-the-art in statistics and biostatistics for issuing predictions over time, such as hidden Markov models. A disadvantage, though, of hidden Markov models is that they do not consider the past history. Everything is Markovian, meaning that the entire history of a patient is compacted only in the current state, and only the current state is used to issue predictions for the patient in the future. By combining the power of recurrent neural networks to learn versatile deep probabilistic representations that are complex and non-stationary, meaning that we don't only consider the current state, but also how all the past history of the patient may have played a role in issuing the current prediction, we are able to combine this power with the interpretability of hidden Markov models. How do we do that in the attentive state space model? Is by creating still states like in a hidden Markov model that are related to the progression of a patient through time. But unlike in a hidden Markov model, we are not only issuing probabilities of transiting to a next state in the future based on the current state, but the entire past history. This is highlighted here with these different weights, which you can see play a different role at different moments in time. These attention weights that we have introduced here enable us to see how much the fact that the patient has been in a particular state in the past and the duration that it has been in a particular state in the past shape our predictions for this patient moving to a particular disease state in the future. They also consider not only the history, but also other contextual information of the patient, such as genetic information. And the memory of such attentive state space model is shaped by this patient's current context, which is formed by both clinical events as well as potential treatments. Why is such a model powerful? Because it represents a superset of many other models, both from deep learning as well as statistics and biostatistics. So we can learn with a very versatile model how much flexibility we need for a particular disease and data set to be able to have good models of disease over time. And in this way, we are able to understand how much history and past history may matter for one disease and one class of patients, but maybe not for another. What you can also see is that this represents not only a very interpretable way to think about trajectories, but also represents state-of-the-art in machine learning and statistics in terms of predictions. And we are not only issuing predictions for one disease, but rather for a variety of morbidities and events of interest. What you see here is a result from the area of cystic fibrosis, which represents a complex disease where patients are usually having many underlying morbidities and comorbidities that need to be tracked and treated over time. And what you can see here is that the attentive state space model not only is able to issue highly accurate predictions, but also is able to identify what are events of interest, both in terms of the value of biomarkers in the different stages of the disease, as well as what is the probability of a particular comorbidity to exhibit itself in a particular stage of the disease. This brings me to the next stage of my talk, in which I'm going to talk briefly about modeling with machine learning morbidities and comorbidities. It is well known that this represents an important frontier currently in medicine. Yet the tools for modeling these complex diseases and the relationship between them is limited. Currently, we deal with one-size-fits-all models. So often we will have a morbidity network that's done at the population level. And this is very unfortunate because in reality, different patients, depending on their genetic characteristics, gender, and maybe other information, socioeconomic factors, may have a different evolution of morbidities and comorbidities over time. So we need to move from a population level, one-size-fits-all model to a personalized model. That's number one. Another one is often these morbidities and comorbidities are modeled as a network that is static. And we know that this is not the case. Often, depending on how long a particular morbidity was there in a patient in an untreated way, this will trigger other morbidities and comorbidities. So we need to model correctly the duration of these different morbidities and comorbidities, not only the fact that they are present in the patient. So we need to move from a static model to a dynamic model. And this is what we have just done a year ago, where we have built a new dynamic and personalized methodology for building comorbidity networks and learning from them. We call this methodology a deep diffusion process, and the focus of it is to model the temporal relationship between disease onsets through dynamic graphs that are personalized to the unique characteristics of the patient. In this way, this dynamic deep diffusion process is able to model events as a multidimensional point process with an intensity function that's parameterized by the edges of the dynamic weighted graph while being aware of the unique characteristics of the patient. Now, let us go one step further and say what can be done, again, using automated machine learning, but not like in autoprognosis case for static predictions, but rather for longitudinal predictions, which represents an important frontier for clinical care. For that, we have developed an automated machine learning framework that we call Clairvoyance, which is a unified end-to-end pipeline for clinical decision support, which again can craft analytics over time at the push of a button. It enables to not only build trajectories of disease, but also identify treatment plans, as well as identify what information we should monitor for the patient and when. So we are able to issue in this way analytics for personalized prediction, personalized treatment planning, and personalized monitoring in an integrated way. And this represents an important milestone in machine learning for healthcare in the longitudinal setting, because prior to Clairvoyance, there existed no common resource for machine learners or clinicians to be able to bring, to answer questions in a longitudinal setting. Now with Clairvoyance, we are having a very powerful solution to build such analytics at scale for a variety of problems. I hope you are going to take a look at this tool. I'm going today to just briefly highlight some of its ingredients. It contains many different methods, from static to dynamic data imputation to a variety of prediction methods, monitoring, as well as interpretations. Today, I'm going to highlight how we can look at treatments and treatments over time. I'm going to briefly describe active sensing for determining monitoring of patients in a personalized way, and talk briefly about how we can make these methods more interpretable. Let me start with personalized therapeutics. We know that different patients may respond differently to different treatments at different moments in time. And often when a clinician is faced with a new patient or a patient that has seen for some time, they may wonder whether a particular treatment is best for a particular patient at this moment in time. And this is a complicated question to answer, because we know that treatment effects are often heterogeneous. One way in which currently clinicians may believe that they can answer this question is using clinical trials. But the reality is that clinical trials are not a good way to solve and address this problem. The reason is clinical trials are, of course, the golden standard and will remain the golden standard for identifying treatment effects. However, they enroll only limited amount of patients. These patients are often not the characteristic patient. The patients that are elderly or may have comorbidities are often not enrolled, as we see even from a trial such as the trial for COVID-19. Also, the clinical trials are limited in the time that which they trace a particular patient. So while clinical trials are very useful, we need to go beyond that if we want to estimate heterogeneous effects for a particular patient to enable personalized therapeutics. That being said, machine learning can play an important role in bringing current clinical trials to the next level. And the area of adaptive clinical trials using machine learning represents an important frontier. Our lab does a lot of work in this area. I'm highlighting here some of our recent papers in clinical trial using machine learning, but I'm not going to talk about this today. Also, we have done recently quite a lot of work together with a variety of pharma partners to highlight what is the power of machine learning for revitalizing clinical trials in the era of COVID-19, both for COVID-19 medication as well as other clinical trials, such as clinical trials for cancer, which may have been stopped. Please take a look. Today, though, I'm going to talk about how we can use observational real-world data after a clinical trial to be able to identify which treatments are best for a patient and when. And this is the frontier, I would say, in estimating personalized therapeutics. It enables us to do that in a scalable and adaptive way, using real-world observational data from representative patients, and it can be done at a low cost. If you want to learn more about this topic, we have recently written a very comprehensive article highlighting the wealth of research we have done over the last 6 years in this area. Please take a look. Today, I'm going to only highlight one of these works. But before I do so, I'd like to highlight why this is a much more complex problem than that of prediction. It is not a simple supervised learning problem like the risk scoring prediction or even the longitudinal prediction that I highlighted before. And the reason behind that is we do not observe counterfactuals. We often have data sets such as the one I'm highlighting here. We have patients which have characteristics X and which may have been treated or untreated. I have here W equal to 1 if the patient was treated and W 0 if the patient was not treated. And we only observe what has happened if the patient was administered that particular treatment choice. We do not observe counterfactuals. We cannot answer, we do not have in the data the counterfactuals. We do not know what would have happened to these patients if they would have been treated differently. Here, for the simplicity of explanation, I'm just considering 2 treatments, treated and untreated, but this framework can be used for more than 2 treatments. Here, I keep it simple though, just with 2. And what we would like to estimate from this observational data is the true causal effects. What will be the effect of this treatment if, for these particular patients if we would have treated them otherwise? And this is a complex problem because this is not, as I mentioned, a supervised learning problem because we do not have explicit labels. We do not observe counterfactuals. Another reason why this is a complex problem is that unlike clinical trials, observational data is biased. It's biased by the clinical practice. And we need to learn in the presence of such biased data. The lack of counterfactuals and the bias in the data are 2 main challenges and associated with this particular problem. Again, if you'd like to read one relatively easy to read introductory tutorial paper about this topic, I would like to point you out to this tutorial which we have written recently. Today, I'm going to focus on a more enhanced version of this problem where we are trying to estimate the effect of a treatment on an individual over time. So we have observational data from electronic health records, and we would like to estimate on the basis of this information how to best treat a particular patient in the future. We learn on the basis of the observational data we have. We build a machine learning model that we validate, and then at runtime, we are going to apply this for a new set of patients. What type of questions can we answer then? For instance, given the current history of the patient so far, we can decide whether to treat a particular patient at a particular moment in time. And what is the optimal time at which we should start treating or stopping treatment? And what type of treatment we should be using at what moment in time, or what combination of treatments we should be using. We are able to do so using individualized treatment effect estimation from such observational data and answer what-if questions. We can also go back to the past to patients that we have seen already and ask ourselves, what would have happened to these patients if I would have treated them differently? So I could use this tool both for understanding as well as predictions in the future. So how do we model this problem? We have longitudinal patient observational data that contains time-dependent patient features, time-dependent treatments, as well as static variables. And as I mentioned, this represents the patient history so far. And what we would like to do is we would like to estimate the outcome for a particular treatment given the patient history. Again, note that we only observe the factual, but we would like to be able to estimate also the outcomes that we would have obtained if we would have decided to treat the patient differently. And again, we are going to issue these predictions on the basis of biased observational data. This problem has been formalized a long time ago, already by Neyman and Rubin, but more recently has been formalized by Robbins and Hernan in the longitudinal setting. And it is the longitudinal setting that poses some new challenges. What you see here is we are estimating the different outcomes, and because again we observe, because we want to estimate different counterfactual trajectories, I'm calling that potential outcomes under different planned sequences of future treatments. And we will need to make two assumptions that are quite strong in order to be able to do so. That of sequential overlap and sequential strong ignorability. In other words, that we do not have hidden confounders. This is a strong assumption that in our recent research, we have started to relax, especially in the time series setting. Today, though, I'm not going to talk about that, but if you are interested in these frontiers of machine learning for causal effect inference, please take a look at our website. The challenges in using such longitudinal data for estimating individualized outcomes is that the patient history contains time-dependent confounders, and they are going to bias the treatment assignment in the observational data set. And these patient covariates are affected by past treatments, which then influence future treatments and outcomes. And we will need to deal with the bias from these time-dependent confounders. The way in which up till now we were able to handle such time-dependent confounding bias was in statistics using marginal structural models, and more recently using machine learning techniques on top of these methods by our lab using recurrent marginal structural networks. And these methods use inverse probability of treatment weighting to deal with this time-dependent confounding. However, this inverse propensity treatment weighting creates a pseudo population where the treatment probability no longer depends on the patient covariates. And in this chosen population, the counterfactual estimates are unbiased. However, using such inverse propensity treatment weighting results in high variance estimates due to extreme weights, as well as is numerically unstable when the treatment probability is very small. So to deal with these challenges, we built a new machine learning method that is learning representations using counterfactual recurrent neural networks. So it's able to deal with these time-dependent confounders by building treatment invariant representations using domain adversarial training. For that, we use a sequence-to-sequence architecture as shown in here. The encoder, which is shown here on the left side of the slide, uses domain adversarial training to build at each time a representation of the patient history that is treatment invariant. And this breaks the association between the patient history and treatment assignment, thereby removing the bias from the time-dependent confounders. And then the representation is passed to the decoder, which is continuously updating this representation while estimating the outcomes. We have tested this type of model in a variety of synthetic data as well as real data. Here is a model for cancer tumor growth from nature that we have used to test in a semi-synthetic setting our method. And the advantage of that is that we can control in the semi-synthetic model parameters that are controlling the amount of time-dependent confounding. I'm not going to go in view of time to the details of this analysis, but let me say that the performance improvements are significant as opposed to marginal structural models, inclusively deep learning-based marginal structural models, both in terms of estimating accurately treatment accuracy as well as the treatment timing. Again, more about this on our website. In view of time, I'm going to go very, very fast on the next slides. I'm going to tell about the fact that we are able to learn on the basis of longitudinal data, not only to issue predictions and estimate treatment at the individualized level, but also determine what information we should acquire and when, thereby being able to do personalization. So rather than use whatever data we have and ask the patient to come back for a new screening or test at a fixed amount of time, we can estimate when is the ideal time that the patient should come back because our uncertainty about their treatment or their trajectory is highest, and what information we should acquire about them at that moment in time. For that, we have built an active sensing approach that is able to learn this in a personalized way. Also, we are able to issue interpretations associated with our predictions. And this is important because clinicians don't want only to issue predictions, but also understand and interpret these predictions. Also, we want to have trustworthy predictions. So we want to have confidence estimates associated with the various predictions. In terms of interpretability, we are also aware that different users may need different forms of understanding. Clinicians may want one type of interpretations, while medical researchers may need to validate data-induced hypotheses, thereby enabling other types of interpretations, by requiring other types of interpretations. And finally, patients may be interested, how can they act? What can they do to improve their treatment, their trajectories of disease and their outcomes? So different types of interpretability may be needed for them. So there is not a one-size-fits-all approach to this. If you are interested to learn more about our work on machine learning interpretability, please take a look at this Turing talk I gave last year, just at the beginning of this pandemic, which was given at the Royal College of Physicians. In view of time, I will not go into the details of this. But what I'm going to say is that this type of tools can be used for a variety of diseases and treatments, both in cancer, in cardiovascular disease, in cystic fibrosis, but also in the era of COVID-19. And if you are interested to see what our lab has done to empower clinicians in the era of COVID-19, from better managing limited resources to personalized treatment, to informing policies and improving collaboration, to clinical trials, to managing uncertainty, please again take a look at our website and reach out to learn more about this. And my final slide is going to appeal to all of you clinicians and medical researchers interested potentially in machine learning to see machine learning as a tool that you can use to derive actionable intelligence to empower you, whether it is in clinical practice, to enable you to make new discoveries, to integrate a variety and wealth of data across a variety of domains, from omics to clinical data to imaging. And last but not least, to understand better both the development of new therapeutics for different classes of patients, but also understand what treatments we should use for what patient and when. Again, we are very interested in our lab in this area, but also in recent times, we have started a center in Cambridge that we call the Cambridge Center for AI in Medicine, and we bring together clinicians, bioscientists and machine learners together to develop new horizons in machine learning for medicine. Please take a look at our center. And again, if you want to get involved with us, subscribe to our Revolutionizing Healthcare session. Thank you so much.
Thank you so much, Mihaela. That's a fantastic talk, and you've taken a very complex topic and made it understandable for people not in the field. So well done on that, and thank you for that. We've had some questions coming through, and we're just seeing if we can actually invite the people who sent the questions to put them forward. So while we work on that, I might just kick off and ask you a question. You highlighted some of the potential issues for trials and how long they can take to respond to people having symptoms or different treatments. And I was wondering if things that are very quick moving, something like COVID-19 is either already being addressed or been addressed. So in terms of people having different symptoms or in terms of what treatments maybe are best suited. Do you know if these methods are being used to address questions like that?
Yes, two answers to your question. One about clinical trials and one more related to observational data and how can we use observational data to understand what treatment may be good for what patient and when, and how this can inform both new clinical trials as well as better treatment. So in terms of how we can use machine learning to better understand what treatments are best for our patients for COVID-19, I invite you to take a look at this recent article we have written on machine learning in the era of COVID-19 for clinical trials. So I will not say too much about that, but I'm going to mainly say that that work is not only enabling us to understand what treatment may be good for what subclass of patients, but also helps us understand for clinical trials that have maybe been stopped, what can you do in this era of COVID-19? How can you empower them from and how you can restart them and reuse information from the trial prior to the pandemic? And for COVID-19 specifically, that article talks about how we can use information from different centers and possibly different countries to increase the power of such studies using machine learning. But what I think is even more exciting, in the hospital currently, clinicians, especially hospitalists, ICU doctors, are very inventive and innovative in terms of treatments that they apply to their patients, and they are trying the impossible. And in this process, they have identified different interventions that may work quite well. So we are working together with University of Amsterdam Medical Center to use these machine learning methods to identify whether indeed we have confidence that they could be useful and for which classes of patients. So as we speak, we take this technology to a particular problem and data set and clinical problem in Amsterdam. But I invite multiple of you who may be interested in this to consider these tools and use them to ask hypotheses and validate hypotheses in your own setting and your domain.
Hello?
Karen, I think it's probably worked. So Sarah, if you are unmuted, Sarah Darby, I know you had a question. Hopefully that will go.
Thank you very much. Hello, Mihaela. I'm Sarah Darby, and I'm a medical statistician in the Nuffield Department of Health. Thank you very much for an interesting lecture. I'm sure that machine learning has a lot to offer in lots of branches of medicine, but I was very troubled by one of the examples that you gave, and that was inferring the what-if questions for treatments. And in my own experience of treatments for breast cancer, on the basis of population data. I mean, as you pointed out, this involves the assumption that there are no hidden confounders. And I mean, my response to that is that on our own studies of observational data on breast cancer patients, looking at their outcomes and everything that's recorded about them, that's just not a realistic assumption. So I wondered whether you could comment on that.
Yes, so thank you very much for this question. So again, multiple answers there. So first, again, we are often, when we are tackling these problems, making this assumption, but not always. Increasingly, the frontier has moved and we are able to learn and deal with hidden confounders, and methodologies have been developed to learn from data sets from different populations in different settings to alleviate this problem of hidden confounders. However, when treating diseases such as cancer, most of the time, I would say, by working with clinicians who know about what are the variables that are most important and that are most relevant for a particular treatment, we can make sure that we take into considerations all the variables that are important. As a matter of fact, when a clinician makes a decision to give or not give a treatment, usually they at least will consider that they have had to their availability all the information they needed, and that information is recorded. So that assumption is, of course, not always true, but if that information is available, then all relevant confounders are present. Let me also say that one way to validate these methods is by, at times, being able to use observational data to estimate and predict what clinical trials will say later. So another way to validate some of these methods is to use them to predict what the clinical trials that may have followed will say. So that being said, this of course represents an important frontier of this area. We know that we not always can do clinical trials. At times clinical trials may be impossible or unethical. And this technology is trying to move boundaries and try to understand how far can we go to better understand effects of treatments and effects of treatments in subpopulations. This also is important not only for biased data, but even for clinical trials. So current work, even for clinical trials where we are looking at population and subpopulation, thereby moving from average treatment effects and estimate whether in a particular subpopulation the treatment may have been more or less efficient, these methods also are useful in that setting. So kind of a long story. This represents a frontier in this area. I'd say a lot of advances have been made. I think in many settings, we do not need to worry about hidden confounders. When we do need to worry, technology has been moving to address these issues, but a lot more work needs to be done. And even on clinical trials, these technologies can be extremely helpful.
In the interest of time, we have time for 2 more quick questions. So I'll now invite Professor Hunter to put forth his question.
Hi there, can you hear me?
Yes.
Wonderful. Very interesting talk. I just had a quick question about heterogeneity. So you stressed that obviously reproducibility of predictions is critical and the way you essentially measure success. But for an individual, you obviously can't rerun the natural history of their disease or the course of their treatment. So then you're back to taking averages of large numbers of people that we try to make similar using statistical means. But as you pointed out, there's great heterogeneity between people. So aren't you back to the problem that the heterogeneity between people is always going to limit the individual prediction probability and power? And your sort of critique of clinical trials was we're sort of taking an average effect, but we can never actually get the individual effect without being able to retest the reproducibility in other people, which means we're always looking at an average effect.
Thank you for this question. No, so this is not a problem. So first, I want to disentangle many things that you have said. So one of them is about predictions and time series predictions. In that case, there is no problem of confounding. There is not the problems that were mentioned before. So it's very easy in that setting for a particular individual to be able to determine what will be the prediction for them in the future. And you can say, I'm going to predict a particular biomarker or event of interest in the short run, in the long run. And you can estimate indeed whether this particular individual prediction has been correct or not. And you can see how this population, how this particular individual prediction may be differing from the population. And that is not a problem, it's not an issue of counterfactuals there, it's just an issue of prediction. And moreover, we can also issue confidence estimates at the personalized level associated with this prediction. both credible intervals, if we have Bayesian methods, as well as if we have frequentist methods, we are able to issue true coverage estimates. And it may be that for certain patients, we may be more certain about these predictions over time, and for others not. So issuing predictions, both static as well as longitudinal, not answering what if questions, but answering predictions and estimating predictions, that is absolutely not a problem. We don't have these problems of hidden confounders, and we are able to estimate predictions and predictions over time. And definitely we should move from average models to more personalized models. And of course, being aware of the fact that maybe personalized predictions for some individuals may be very accurate, while for some others may not be. So this is all possible. And has nothing to do with clinical trials. That being said, I'm going to go back that if you indeed are trying to answer what if questions for treatments, not for predictions, what would have happened if I would have treated at a different moment in time, then the confounding problems does play a role. And as I answered to the previous talk, at times you need to rely on these methods because there is nothing better than that. Clinical trials cannot even be done in many settings, are either unethical or may not follow the patients for long enough. And then you are stuck to either making these assumptions that you do have all the hidden confounders, or you need to, like in our group, do a lot of research to deal with hidden confounders and solve the problems associated with that.
And we have time for a very quick, lucky last question from Professor Collins.
Thanks very much, Mihaela, for the talk. You mentioned that randomized trials aren't representative, but of course, neither are observational data representative, in the sense that the people who get treated are not representative of the ones who don't get treated. It's a different way of looking at confoundedness, if you like, and also kind of overlap. But the issue I see with this is, and I take the point there are times when you can't do a randomized trial, therefore you can't do a randomized trial. What I'm concerned about is where you can do a randomized trial and you imply that observational studies would be an alternative. And I think that is unfortunate because as you point out in the Beaker paper, you're really only going to know when the observational study can be relied on when you have a randomized trial that confirms it. So the knowledge you're getting is retrospective, which is not terribly helpful, but it's also not generalizable. It's not generalizable to the next treatment or the next situation. So going back to Sarah Darby's comment, and I think your response, the idea that clinicians know about all the confounders, I think is somewhat clinically naive.
So thank you for your question. So first, I'd like, in view of time, I'm going to respond to this question, but I invite you to take a look at all the different work that I posted. So going beyond the BCAS paper, which is just a tutorial, to some of the papers that we have published that show what you can do even in clinical trials. So let me start with the first point you made, which I agree that when we have observational data, biased data, indeed, patients are not treated or untreated by their clinicians in an unbiased way. And is indeed exactly what these methods are trying to do. They try to deal with bias and the bias in the data, and it's one of the problems that is addressed using machine learning methods that I described. So we deal with both unconfoundedness, but also bias. Then another setting that I'd like to highlight is these methods are even useful to understand and improve the understanding of clinical trials. So we can do using these methods post hoc analysis of clinical trials to understand better subpopulations and subpopulations which would most benefit from a particular treatment. Often, as is well known, a particular treatment may have bad or good outcome in the average, but not in subpopulations. And again, some of these methods represent a new frontier where we are able to identify on the basis of the clinical trials subgroups that may benefit or not from a treatment. And again, I invite you to take a look at some of this work. Finally, it is I would say, naive to believe that we only can validate things using clinical trials. I really believe that if we can do clinical trials, I completely agree with you that we should apply them and we should use them. But in many settings, we really cannot. And in those settings, I think technologies like these ones are providing at least some initial understanding of what treatments may be best for what patients. And then you could take some of this work and you can do clinical trials if that's possible. If not, you may need to find other ways to validate that, either by doing experiments, observational experiments, try to do through causal discovery, and try to understand whether what has been found using these hypothesis generation methods is really true. So I'm not saying that you can use this off the shelf, but I do think that these technologies both can empower clinical trials, provide hypotheses, as well as provide a complement to clinical trials in many settings. And especially this is the case in longitudinal settings. Thank you so much.